Founded with a steadfast commitment to delivering unparalleled education, the Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving.
Good morning and welcome to the Resuscitation Essentials for Moonlighters, or R.E.M webinar. We want everyone to have the best learning experience possible, so please observe the following guidelines during the lecture. First, please keep your microphones on mute. Second, you are invited to type in your questions in the chat box at any time or ask them live at the end of the lecture. Lastly, the attendance link will only be posted in the chat box at the end of the webinar. A pleasant morning once again and enjoy today's lecture. Good morning and
Good morning, ladies and gentlemen, esteemed colleagues, and young doctors. Greetings and welcome to our distinguished webinar series, R.E.M, Resuscitation Essentials for Moonlighters, a tribute to the decade of excellence at the Academy of Emergency Sciences. As an accredited American Heart Association training partner for BLS, ACLS, and PALS, we have consistently upheld the belief that resuscitation is not merely a task, it is our unwavering calling. Our motto, "Resuscitation is our calling, education our passion," underscores our enduring commitment to the art of life-saving. The choice of the acronym R.E.M for this webinar is not by chance. It reflects a profound connection with scientific research, suggesting that R.E.M sleep is when we most effectively consolidate learning and memory. Today, we gather to deepen your knowledge and enhance your resuscitation skills, with the firm belief that the wisdom imparted here will translate into lives saved. This year-long webinar series is generously offered free of charge, our humble contribution to advancing the realm of resuscitation education. We are resolute in our mission to empower young doctors and healthcare professionals with the essential knowledge required for their arduous moonlighting shifts. We express our profound gratitude for your presence here today, and we invite you to embark on this journey of enlightenment with us. Together, let us strive for excellence and remember, resuscitation is our calling, education our passion. It is with great anticipation that we look forward to collectively advancing our understanding and proficiency in resuscitation.
Good morning, everyone. It is my distinct honor Good morning. Good morning, everyone. It is my distinct honor to be introducing our speaker for today. So, Dr. Alin Castre finished his Bachelor of Science in Nursing at the Xavier University Ateneo de Cagayan and took up his Doctor of Medicine at the same institution. He further on went to pursue further training in the Master of Arts in Health Professional Education at Xavier University Ateneo de Cagayan. Currently, he is an associate professor for the College of Medicine at USTP and assistant professor at the College of Medicine for Xavier University Ateneo de Cagayan College of Medicine. He is also an instructor for the College of Nursing at the Xavier University Ateneo de Cagayan and is an active BLS and ACLS instructor for the Academy of Emergency Sciences under the American Heart Association. Colleagues, friends, let us all welcome our speaker for this morning. We are very privileged to have him, Dr. Alin Castre.
Good morning, everyone.
Morning, Doc.
Good morning,
We
Doc
can see
Pao.
and hear you loud and clear.
Right, thank you. Thank you very much. Good morning, everyone, and thank you for joining us this morning. So, I was assigned to talk about CPR through the years, the evolution of CPR guidelines. So, Doc, I'll share my screen now.
Okay, go ahead, Doc.
Thank you. I hope everybody is able to see this.
Yes, Doc, we can see your slides.
Thank you. All right. Before I start, sayang pala no, we have soon to be colleagues who are not able to join us today because they are taking their physician's licensure exam. So let's pray for them, and good luck and God bless to them all. So yeah, I'll start. So I'll start with a quick introduction. So what if we picture ourselves in a critical moment, whether in the ER, on the ward, or even outside the hospital walls? A patient's heart stops, and you happen to be in your scrubs, and everyone is counting on you to act. Well, that's probably the reason why you're here with us now, training with the Academy of Emergency Sciences. And we've been learning a lot since we've started these sessions, and especially during our classroom trainings. But how did we arrive at the CPR techniques we rely on today? The science of saving lives through CPR has evolved a lot, and I believe understanding its journey helps us become more effective as healthcare professionals. So, this is our lecture on CPR through the years, the evolution of CPR guidelines. And in this lecture, we'll take a deep dive into how CPR has transformed from its early origins to the advanced evidence-based techniques we practice today. As physicians or nurses or healthcare workers in general, whether you're seasoned or newly licensed, mastering CPR is a fundamental skill, right? But understanding why and how these guidelines have changed over time adds another layer of expertise to your practice, to our practice. Together, we'll explore the science, research, and the pivotal moments that have shaped CPR into the life-saving tool it is now, ensuring that the next time we're called to act, we do so with both skill and understanding. So, one of the earliest known accounts of resuscitation can be read in the Bible somewhere around 896 BC, where Elisha used what appears to be a form of mouth-to-mouth resuscitation. No? In the book of Second Kings, Elisha, after lying on a child and placing his mouth over the child's mouth, he successfully revived the boy. But whether it was through warming or a true attempt at resuscitation, or as many would believe, divine intervention, this early story gives us a glimpse into how people viewed life-saving measures long before modern medicine. And it reminds us that the desire to restore life was always there, even in ancient times. And many took on more aggressive approaches. Common method was the flagellation method, where rescuers whipped victims with sticks or branches, and struck them with their hands or wet cloths in an attempt to provoke a response. Imagine being brought back to life by such a technique. No? It's clear how desperate people were to try anything that might work. And because death caused the body to become cold, people also tried to restore the body's heat by applying heat to the body, whether it was warm ashes or hot water or even burning dried animal feces. No? So it was not a nice time to be dying. Now, moving on into the 1400s, we find one of the earliest records of what might be considered chest compressions. An Iranian physician, Nafis ibn Iwad el-Kramani, or also known as Burhan Uddin, advised in a book to stimulate a patient by shaking them, moving their arms, and compressing the left side of their chest if they had a weak or absent pulse. So this is one of the earliest indications of the concept of using physical manipulation in resuscitation. And in 1472, the Italian physician Paulus Bagallardus, author of Libellus de Egritudinibus Infantium, fancy words for it's just the first printed pediatric book, describing the care of the infant from birth to the first month of life. So here in his book, he gave advice to midwives on how to resuscitate newborns, blowing into the mouth of the baby if the baby was warm but not breathing. But interestingly, he also suggested blowing into the infant's anus if there was no response. So probably Bagallardus did not really recognize the real significance of his advice. Now, the Swiss physician Paracelsus in the 1500s probably had more logic when he introduced the use of bellows, a device commonly used for stoking fires in fireplaces. He recommended inserting the bellows into a victim's mouth to introduce air into their lungs. This technique actually became the standard for nearly 300 years and marked the first practical attempt at artificial ventilation. Kaya lang, some of the side effects that were mentioned when I was reading were deposition of ashes and also burned airways because, of course, the thing that he was using was used in the fireplace and was probably hot and had hot ashes inside it. But yes, it was used, the technique was used for almost around 300 years. Now in 1955, the modern technique of tracheotomy and positive pressure ventilation was introduced by Andreas Vesalius. Oh, meron na pala noon. Well, by inserting a tube of reed after making an opening in the trunk of the trachea and blowing into it so that the lungs may rise again. But this was forgotten for over a century. In 1667, however, Robert Hooke, yes, the one who discovered the cell, no? He challenged the idea that it was the lack of movement of the lungs, but rather the lack of continuous supply of fresh air that was necessary to stay alive. So he proved this by opening the thorax of a dog and keeping it alive by pumping fresh air in and out of its lungs. So the dog was able to live for a few more days. But the first to document a detailed clinical description of the successful use of resuscitation in a person was done by a local surgeon from Scotland, Dr. William Tosak. So when he revived a coal pit miner suffering from suffocation by using mouth-to-mouth resuscitation. So this happened in 1732, but it was recorded, it was documented in around 1744 pa. So 8 years later, the Academy of Sciences in Paris officially recommended mouth-to-mouth resuscitation for reviving drowning victims because of this report. Now, in 1774, there were two physicians from London, Thomas Coogan and William Hawes, who founded the Society for the Recovery of Persons Apparently Drowned. Well, it's a mouthful, no? But it was later named Royal Humane Society. And they initially recommended the technique, the mouth-to-mouth resuscitation technique. But then in 1782, they withdrew their recommendation. And they stated that their preferred method was the bellows method now, which is why the bellows method remained one of the most popular CPR methods until 1829. Why? Maybe because of hygienic purposes na siguro. Maybe because by then they were realizing that mouth to mouth was not very hygienic. So in the years that followed, drowning became a major public and medical issue. So similar organizations soon sprang up in many large cities in Europe and the US, all with the goal of successfully resuscitating victims. And with that, a number of approaches to resuscitation also came out. No? Apparently, it was still not clear to everyone why people breathed and why people became pulseless. Many, especially those without medical backgrounds, thought that people were unconscious because of a lack of stimulation. So this hypothesis led to a number of unusual treatments, where the goal was to stimulate the patients. So this included, bumalik yung flagellation in 1770, and they went as far as hanging them upside down. No? There's also this one method from Russia by cooling them on ice, or using the fumigator in which smoke was blown up the patient's rectum. So some others, though, still believed in trying to get the victims' chests and lungs to push air in and out. So thus they tried rolling them over barrels, and in 1812, placing them on a trotting horse so that the bounce of the body on the horse would push the air in and out. No? This trotting horse method in particular was done by lifeguards at the beach trying to revive victims of drowning. No? So when a victim was rescued and removed from the water, the lifeguards would place the victim onto the horse and run the horse up and down the beach. No? So this resulted in an alternate compression and relaxation of the chest cavity as a result of the bouncing of the body on the horse. However, this procedure was banned across the US in 1815 because of complaints by an organization called Citizens for Clean Beaches. So apparently, iba ang priority nila. And after that, until the early 20th century, the Hall and Sylvester methods became the most commonly used forms of artificial respiration. So what are these Hall and Sylvester methods? Marshall Hall was a physician from London who proposed the Roll method. So, he recognized a major issue we now know well, where when we leave a victim supine, it could cause the tongue to fall back, right, and block the airway. So he developed a manual technique where the victim was rolled to their stomach, from their stomach, so prone position, to their side, back and forth, about 16 times per minute. And he also applied pressure to the back when the patient was on the prone position to help with exhalation. Okay. But a couple of years later, Henry Robert Sylvester identified problems with the method of Dr. Hall. So what he noted was that the volume of air exchanged during that technique by Dr. Hall, they were too small to be effective. And also, rolling a lifeless body was not only impractical, but also could cause serious injury to the cervical spine and the face. Okay, so he responded with his own method, where he proposed that raising the victim's arms above their head would aid in inhalation and then alternating with pressing the arms against the chest, which would help with exhalation. So this process was repeated several times per minute. And then in 1868, Dr. John Hill from Royal Free Hospital described the use of sternal compression. So this is the first time that sternal compression appears. So he does this at a compression rate of 12 times per minute. And he actually reported success in 3 patients. But in these 3 patients, the chest compressions here appear to have served primarily as a means for the inhalation of ammonia from a sponge held close to the nostrils of the patient. So if we notice, all of these attempts that I've mentioned were so focused on breathing. No? It was not until 1874 when Moritz Schiff, a German physiologist, noted that the heart stopped beating first before breathing stopped. No? So he recognized that typical methods of resuscitation by ventilation were insufficient once the heart had stopped. So he proposed a radical new approach. This is the internal cardiac massage. So he argued that by opening the thorax, you could manually compress the heart with their hand to squeeze blood out and artificially stimulate circulation. And he also recommended simultaneously to slowly blow air into the lungs and compress the abdominal aorta to direct blood toward the brain. Incredibly, Schiff found that this technique could successfully restore the heart's function as long as 11.5 minutes after it had stopped beating in dogs. Okay. But 3 years later, 1877, sinigundahan naman ito ni Rudolf Boehm, another German. But now he reported the use of, this time, external carotid massage to resuscitate cats in cardiac arrest. And then in 1892, Friedrich Mays, a surgical resident at the University of Göttingen, was the first to describe the successful resuscitation of 2 human patients, this time using external cardiac massage. Dr. Mays became the first proponent of external chest compression as an effective means of assisting circulation rather than ventilation alone. But the technique does not take hold, and for the next 50 years, open heart massage was the standard. In the US, there was also a doctor named George Kreil, who reported success of external cardiac massage in dogs and in 7 humans. But in the 7 humans, only 1 was successful. So that's why it also did not take hold in the US. So I think that was the birth of external cardiac massage. In 1899, 2 physiologists from the University of Geneva in Switzerland, Jean-Louis Prévost and Frédéric Batelli, they discovered that small electrical shocks could induce ventricular fibrillation in dogs, and that larger charges could reverse the condition of ventricular fibrillation. There was actually an earlier report in 1775 of a certain Danish veterinarian, Peter Abildgaard, who discovered he could restore a heartbeat in a chicken after shocking it with electricity. But it was Prévost and Batelli who were credited for starting the research on the use of electricity to restart the heart. Now we go to the 1900s, where in 1924, 6 cardiologists meet in Chicago, and they organized the American Heart Association as a professional society for physicians. And the year after, scientific sessions begin, no? And the AHA held its scientific session, its first scientific session meeting, where scientists and healthcare professionals learn the latest developments. In the same year, studies on the effects of electricity also start the Johns Hopkins School of Hygiene and Public Health. And in Johns Hopkins, 8 years later, the team was now led by an electrical engineer, Dr. William Kuvenhofen. And their research is on applying defibrillation to open chest cardiac resuscitation techniques in dogs. Okay. In 1946, the mostly forgotten technique of mouth-to-mouth ventilation finally came back when Dr. James Elam accidentally rediscovered the technique when he was trying to rescue paralyzed polio patients when their mechanical ventilators failed. When their lung machines would fail, he tried to give mouth-to-mouth resuscitation while, I don't know, maybe waiting for a replacement machine. Yeah, and he found out that it was successful. In 1947, Dr. Claude Beck was able to perform the first successful use of an electric defibrillator on an exposed human heart of a 14-year-old boy who went into cardiac arrest while in surgery. We also know Dr. Beck for his name, which is associated with hypotension, extended neck veins, and muffled heart sounds, which is also called, right? Beck's triad, right? So he's the same person. Now, defibrillation had now become of regular use, but it was only used in open chest heart restarting. No? So in 1952, Harvard cardiologist Dr. Paul Zoll published a report on resuscitation of the heart using what he described as an artificial external electric pacemaker. So this is the first time that there is a defibrillation using well, not open chest anymore. It's an closed chest external resuscitation using what he called it that time, an electric pacemaker. Well, he later on started the Zoll company that produces defibrillators now, and he's also now known as the father of modern cardiac therapy because he perfected the pacemaker. He's also the one who did research on the internal pacemaker. In 1956, Dr. Elam, if you remember, Mr. Mouth to Mouth, no? He met Dr. Peter Safar, and together they did further research on the mouth-to-mouth method of artificial ventilation. And by 1957, a year after, their experiments had conclusively demonstrated that the mouth-to-mouth method was superior to these older methods of artificial ventilation. And because of this, the US military adopted the technique to revive unresponsive victims. And in the same year, balik tayo sa Johns Hopkins, Dr. Kuvenhofen, now accompanied by Dr. James Jude, and Dr. Guy Knickerbocker, unveiled their prototype of the first portable external defibrillator, but it was on a wheeled cart and weighed 200 pounds or around 90 kilograms. So that was the first portable external defibrillator. But the more interesting story that happened with them happened in the year after, 1958, when they noted while doing their research, they noted that when they applied the heavy defibrillator paddles on the chest of the dog, they noted that the dog's blood pressure temporarily rose. So this led to their accidental rediscovery of applying chest compressions while waiting for the defibrillator charge to be given. No? And the formal connection between the ventilation techniques of Dr. Elam and Dr. Safar and the cardiac massage and defibrillation procedure of Dr. Kuvenhofen and his team actually took place in September 1960 at the annual meeting of the Maryland Medical Society, where they presented for the first time together. And combining chest compressions and mouth-to-mouth ventilation, the term cardiopulmonary resuscitation was born. And the American Heart Association then started a program to acquaint physicians with the closed chest cardiac resuscitation, and the AHA became the forerunner of CPR training for the general public. And for training, they need mannequins to practice on. And the first mannequin was actually called Miss Sweet Breath, and it was invented by Roger Mehalek in 1959. He was a Red Cross volunteer from Michigan. But the second mannequin is what is the most famous, which was designed by Dr. Safar, along with the Norwegian toy maker Asmund Lerdal. Okay, and it has become the most famous in the world. It was named CPR Annie or Resuscitation, which was a mannequin with human features and size. I'm sure you'll see many stories in social media. No? And in 1961, an 11-minute training film was produced. It was called Life in Your Hands, where they demonstrated the new technique of CPR and stressed the importance of air and circulation. And the following year, Archer Gordon and David Adams produced a longer 26-minute training film called The Pulse of Life in 1962. And for the film, Gordon and Adams devised the easy-to-remember mnemonic of A, B, and C, which represented the sequence of steps in CPR: airway, breathing, and circulation. And in 1963, CPR is formally endorsed by the American Heart Association. It was also in this year where the cardiologist Dr. Leonard Shirley's establishes the CPR committee of AHA. So by the 1960s, hospital care units had started to appear, but there was one man who doubted their effectiveness when it came to coronary emergencies, because he observed that that most coronary deaths occurred suddenly outside of the hospital, and often due to ventricular fibrillation. So Dr. Frank Pantridge, a pioneering cardiologist from Belfast, argued that since most deaths were happening far from medical facilities, life-saving interventions needed to take place on the scene, not just in hospitals. The problem, however, was that the equipment that was needed for the interventions, particularly the defibrillator, was very large. Remember, they were very large, and they also required mains electricity, or electricity, main electricity. So in 1965, Dr. Pantridge created the Mobile Coronary Care Unit, MCCU, which is actually an ambulance equipped with special medical devices and trained personnel to provide pre-hospital care. But Dr. Pantridge's most significant contribution was the development of a portable defibrillator. Although the first version weighed around 70 kilograms and it operated from a car battery, it was still too heavy, right? But, well, of course, still better than the the 90 kilogram. Well, it's almost still very heavy to bring around. But in 1968, with advancements in capacitor technology from NASA, he was able to develop a 3 kilogram version. And this revolutionized pre-hospital cardiac care. And Dr. Pantridge's portable defibrillator became a game changer. It enabled treatment at the site of cardiac arrest. And his system, known as the Pantridge Plan, was eventually accepted and adopted by emergency services worldwide, right? And that's why he's also known as the father of emergency medical services. In 1966, the National Research Council of the National Academy of Sciences convened an important conference in response to disappointing results with early CPR training. So while CPR training was going on, and it was being taught to both lay people and professionals, daming bagsak. No? Fewer than 50% could pass a performance evaluation just 3 months after training. And the survival rates for cardiac arrests occurring outside the hospitals were dismal. So this was clearly a problem that needed to be addressed. So at the conference, it was recommended that all medical and allied health personnel be trained in mouth-to-mouth resuscitation and external chest compressions. And the result of this gathering was the development of the update. No? So these guidelines laid the foundation for standardized CPR training, making it an essential skill, not just for healthcare professionals, but for the public as well. Interestingly, at that time, the guidelines recommended a compression rate of 60 compressions per minute. And the compression ratio for one rescuer CPR was 15:2, while for two rescuer CPR, it was 5:1, quite different from today's recommendations. No? They had a second conference in 1973 with the American Heart Association, and it was decided that CPR training should be extended to the general public and not just healthcare professionals. And recognizing that the medical science is ever evolving, it was decided that updates to these standards should occur every 6 years to ensure that the methods reflected the latest knowledge. And in 1975, the AHA publishes the first ACLS textbook. In 1983, the AHA convenes a national conference on pediatric resuscitation to develop CPR and emergency cardiac care guidelines for pedia and neonatal patients. And in July 1985 was the fourth national conference to make recommendations for changes in the standards and guidelines based on the clinical and scientific data accumulated since the previous conference, which was in 6 years back. So after this conference, they released the 1986 AHA guidelines, no? So the year after. And one major shift in the strategy was it was related to two rescuer CPR. So they noticed na two rescuer CPR was rarely used by lay people because in most emergencies, help usually arrives in the form of emergency medical services personnel or EMS personnel, no, who relieve the lay rescuer. So they decided na what they're going to teach is only one rescuer CPR to the public, to the lay public, so that mas less mental load on them. Okay. Another important recommendation from this 1986 guidelines was the head tilt chin lift technique to open the airway. Additionally, the conference also emphasized the importance of starting chest compressions as soon as a pulse was found to be absent. So by then, it was still a recommendation for everyone to check for a pulse and to start chest compressions if they did not find a pulse. And the recommended compression rate that time was 80 to 100 compressions per minute na, with a 15 to 2 compression ventilation ratio kung one rescuer and 5:1 for 2 rescuer CPR. Again, recommended for healthcare professionals because the lay people were made to focus on one rescuer CPR. Also, during these guidelines, the use of the mouth-to-mask technique was recommended already. And this involved a clear plastic mask with a one-way valve that directed the victim's exhaled air away from the rescuer. So it made the process look safer and more hygienic for the rescuer. And perhaps one of the most groundbreaking realizations was that early defibrillation was the key factor in determining success rates in resuscitation. So the conference strongly advocated for pre-hospital defibrillation by trained EMTs. Now, there was a concern by then that defibrillators could be misused by untrained individuals, no, because they might use it as a potential weapon. So that's why, for that reason, at that time, only trained personnel were authorized to use defibrillators. 2 years after, 1988, a significant milestone in resuscitation was reached with the introduction of specialized courses for pediatric care. So, recognizing the unique needs of children and infants during resuscitation, AHA, in co-sponsorship with the American Academy of Pediatrics, they launched the first pediatric resuscitation courses. So, pediatric BLS, PALS, or pediatric advanced life support, and neonatal resuscitation. Now, moving into the 1990s, a new era began with the widespread introduction of public access defibrillation programs. So, for the first time, defibrillation technology was no longer confined to trained personnel and to hospitals and emergency medical services. So instead, automated external defibrillators were made available to the public. Of course, along with training programs to help lay people confidently and safely use them. Also in 1990, Europe made its mark also in the world of resuscitation with the establishment of the European Resuscitation Council, or ERC. Now, this organization was created to unify and standardize CPR practices across Europe because the AHA was operating in the United States, of course. But this was the European counterpart of AHA. No? So they played similar roles. In 1992, by 1992, most of the CPR guidelines from 1986 remained in place, but the key updates, there were some key updates that were introduced based on the latest research and clinical experience. And well, the recommended compression rate was still between 80 to 100 compressions per minute, with a 15:2 ratio for one rescuer CPR and 5:1 two rescuer CPR, so the same pa rin. Pero a significant new recommendation was added, and this is the for adults, no, calling emergency medical services should be the first step in basic life support. But in contrast, for children, 1 minute of CPR should be performed first before calling EMS, because by then they already decided as that airway support is often more critical than defibrillation in pediatric cases. Another important update focused on minimizing the risk of gastric insufflation during ventilation. So the suggested time for filling the lungs during ventilation was increased to 1.5 to 2 seconds per breath. So it was then when they recommended to give breaths for over 2 seconds to reduce the chances of air entering the stomach instead of the lungs. And in terms of medications, well, the guidelines still recommended an initial dose of epinephrine if no pulse was present, but the use of high-dose epinephrine was not endorsed. Calcium was removed from routine use, and while sodium carbonate was recommended for patients with hyperkalemia. And additionally, adenosine was also endorsed for treating patients with paroxysmal SVT or supraventricular tachycardia. But perhaps one of the most important developments in 1992 was the formalization of the chain of survival. Okay, but that time it outlined 4 critical links to increase the chances of survival for cardiac arrest patients, which were early access, early CPR, early defibrillation, and early advanced care. So while CPR guidelines were being updated in the US, the European Resuscitation Council also released its own set of guidelines for advanced life support, and many of which were similar to the American guidelines. In fact, members of the ERC, or European Resuscitation Council, were invited to the US conferences on resuscitation, which led to greater collaboration. And it wasn't long before the two organizations joined forces to form what we now know as the International Liaison Committee on Resuscitation, or the ILCOR. Okay, and they released updates. They worked on updates in collaboration since then. The year 2000 marked a major milestone in the history of resuscitation because this was the release of the first unified international CPR recommendations developed by AHA, the American Heart Association, and the ILCOR, the International Liaison Committee on Resuscitation, the one in collaboration with the European Resuscitation Council. And one of the key updates in these guidelines was a recognition of the difficulty lay rescuers in checking for a pulse. So instead of relying on pulse checks, the new guideline encouraged laypersons to begin chest compressions if the victim showed an absence of normal breathing, coughing, or movement. So this shift simplified CPR for the general public, making it easier for non-medical persons to initiate life-saving measures in the critical first moments of a cardiac emergency. The guidelines also introduced a simplified compression rate for adults, set at approximately 100 compressions per minute. Sumikat yung yung 100 beats per minute song na, was it by this time? Staying Alive. And this change unified the compression rate for both adults and children. So CPR training became more straightforward. The the compression ventilation ratio was also revised, and simplifying it to a 15:2 ratio for both 1 or 2 rescuer CPR until the airway was secured. So, well, the point of I think what they were trying to do in 2000 was really to simplify CPR so that anyone could do it. In fact, new educational methods like the practice as you watch and the watch then practice techniques, no, those techniques were recommended to improve CPR training and retention. There's also in this update where ventilation using a bag mask device was recognized as comparably effective to ventilation through a tracheal tube. Okay. And another significant development here was the promotion of the AEDs for layperson use. In fact, the AED was specifically designed for non-professionals to use. And there were two key studies that provided evidence for this effectiveness. So one was a study done in US casinos showing that using AED within 5 minutes of a cardiac arrest significantly improved survival rates. And another study, this time in airports, so it also had comparable results. So as a result of those studies, AEDs began to be placed in high traffic areas such as airports, high-rise office buildings, recreational facilities like the casinos, and more. However, at this time, the use of the AED was not yet recommended for children. So, I mean, AEDs was not recommended for use in children under 8 years yet because of lack of sufficient evidence at that time. And in terms of advanced care, the guidelines recommended the use of stacked sequence shocks. No, well, stacked sequence of 3 shocks is giving that's giving 3 straight shocks without chest compressions in between to treat ventricular fibrillation or pulseless ventricular tachycardia. So this approach represented a more aggressive response to cardiac arrest in the hope of improving outcomes in these critical situations. Okay. So here's a summary table on the differences between the 1986, 1992, and 2000, 2000 CPR guidelines. So you'll see that the compression rate changed from 80 to 100 to approximately just one value, 100 per minute. You'll also see that the compression ventilation ratios changed from 15:2 for 1 rescuer and 5:1 for 2 rescuer to a simpler to memorize 15:2 for both 1 and 2 rescuers. It was also in 2000 where training videos were more and more training videos were produced. Now in 2004, the AHA and ILCOR released an important update regarding the use of AED in children. So for children aged 1 to 8 years, it was now deemed appropriate to use an AED if the child had no signs of circulation. Now, this was a significant update because previously, remember, AED use had been restricted. It was restricted to adults only and older children. However, it was still not recommended to use AED on infants because there was still a lack of evidence supporting the safety and effectiveness in that age group. In 2005, there were also groundbreaking changes in CPR guidelines published by AHA. These changes were aimed at addressing persistently high incidence and mortality rates of out of hospital sudden cardiac arrest. So this time, their goal was not just to perform any kind of CPR, but high quality CPR. Again, not just any kind of CPR, but high quality CPR. Because now, that's what we're pushing because we know that if it isn't high quality CPR, it's going to be ineffective, right? So in 2005, in this year, there were also this is also the update in the compression to ventilation ratio for solo rescuers. So it was changed to 30:2 for all ages. So this shift from the previous 15:2 ratio was based on research, so showing that interruptions in chest compressions to deliver breaths reduced blood flow, right, to vital organs, particularly the heart and the brain, which is what we're the principle we're pushing right now. And this contributed to the high mortality rate, the increase in interruptions. So by increasing the number of uninterrupted compressions, rescuers could help maintain higher blood pressure and better perfusion to critical organs. So the guidelines also emphasize the mantra to push hard and fast, push fast, no? Push hard and push fast. Rescuers were encouraged, excuse me, to minimize interruptions with the recommendation to change compressors every 2 minutes to avoid fatigue. And studies had shown that uninterrupted sets of 30 compressions were more favorable for raising blood pressure and pushing blood supply to the critical organs. However, ang 15:2 ratio, the 15:2 ratio was still maintained for 2 rescuer teams performing CPR on children up to the start of puberty, because they recognized that oxygen supply through rescue breathing remained as important as chest compressions in pediatric cases. So the 30:2 compressions was recommended for adults, and whether one or two rescuer, and the 15:2 was maintained, but only for children with 2 rescuers doing CPR. Also, still compression rate was still set at 100 compressions per minute. And yeah, the guidelines also introduced important changes to AED usage. So previously, AEDs were primarily designed for adult use. But now it was recommended that adult defibrillation doses could also be used in children already if there were no pediatric pads available, right? And another major update was the approach in defibrillation during cardiac arrest. So before, we mentioned that there was the stacked sequence of up to 3 shocks without interposed compressions for VF and pulseless ventricular tachycardia, but that was removed in the 2005 update. And here, because the focus was to increase the time for chest compressions, they recommended that immediately after giving a shock, CPR should be resumed immediately, no? Because they saw that continuous compressions improved survival rates. So again, this time, and the stacked shocks were removed, and they recommended immediate resumption of CPR after delivering 1 shock for at least 2 minutes, no? Also, during the 2005 update, therapeutic hypothermia was also recommended. So therapeutic hypothermia is a promising post-resuscitation treatment. It was found to improve neurological outcomes in patients who survived out of hospital cardiac arrest, pero they remained comatose, right? So this technique lowered the body temperature of survivors to help protect the brain from damage during the recovery process. Also, the 2005 guidelines downplayed the emphasis on drug therapy. Although vasopressors, antiarrhythmics could still be administered during CPR, the priority was really on high quality chest compressions with minimal interruptions. So drugs could be administered during CPR or while the defibrillator was charging, but the focus of this year's of the 2005 update remained on compressions, as it was clear that uh, this element of CPR had a very significant impact on survival. So here we see the difference between the 2000 and 2005 updates. Now in 2008, a pivotal shift occurred in how CPR was approached by the public um, because of the research of Dr. Gordon Uwe, funded by the AHA. It was found that uninterrupted high-quality chest compressions without mouth-to-mouth respiration were critical for keeping blood circulating to vital organs. So this research led to a major change in the AHA's recommendations. So for adult victims of sudden cardiac arrest, bystanders were now encouraged to perform hands-only CPR, no? Which involved calling 911 and immediately providing chest compressions by pushing hard and fast in the center of the victim's chest. So this was different from the traditional CPR, which required both compressions and rescue breaths, right? But this actually made CPR more accessible for lay people who might hesitate to perform mouth to mouth, right? And in 2010, in the International Consensus on CPR and ECC Science, which also marked the 50th anniversary of CPR, this resulted in a number of important changes aimed at increasing the involvement of bystanders and improving CPR quality. So, of course, this was a result of the previous research of Dr. Yui regarding hands-only CPR. So then, in the 2010 guidelines, instead of ABC, the CPR sequence was now changed to CAB, compressions, airway, and breathing. So this ensured that chest compressions, which was then recognized as the more important part of CPR, were started sooner because the rescuer would not have to think about giving breaths and would not hesitate to start CPR anymore. So the 2010 guidelines placed increased focus still on high quality CPR. Rescuers were instructed to push hard, to push fast. This time, there was a recommendation now of the chest compression depth. So from the previous recommendation of 1.5 to 2 inches, now the recommended depth was at least 2 inches in adults at a rate of 100 compressions per minute. Of course, it was also emphasized or re-emphasized at this point to allow complete chest recoil during compressions and minimizing pauses, so to improve blood flow to the brain and heart. Okay, and also for healthcare providers who are going to train for advanced care, the guidelines emphasized the need for integrated teams where tasks were now delegated. So there were chest compressions, someone else is in charge of airway management, shock delivery, and they could be performed concurrently, and that maximized the efficiency of resuscitation efforts. So here we can see the difference in the updates on the CPR guidelines in 2005 and 2010, where there was a shift to the compressions first before airway and breathing. They also, in 2010, they also removed the look, listen, and feel. Well, of course, because you didn't need to give breaths anymore. So the breaths were not really of concern here anymore. So in 2015, the AHA released another guidelines update based on the international conference poster conference, which focused now on fine-tuning the science of CPR, particularly chest compressions. So for the first time, upper limits for compression rate and compression depth were introduced. No? So instead of just the approximately 100 compressions per minute, they placed an upper limit now of 120. So it's now 100 to 120 because they saw that the evidence suggested that faster or compression rates that were faster than 120 became less effective. Also, there was another upper limit placed on the depth of chest compressions. So from just 2 inches, now they also placed a limit to 2.4 inches because the evidence also suggested that excessive rates and depths could lead to decreased survival or life-threatening injuries. So the guidelines also emphasized minimizing interruptions in chest compressions. That's why there was now a focus on maximizing the chest compression fraction. And they also set a value for it to aim for at least 60% CCF. No? So if you remember, chest compression fraction is the percentage of time spent performing chest compressions during CPR. And in addition, chest compression only CPR was also reaffirmed for bystanders for out-of-hospital cardiac arrest. For advanced care, the guidelines introduced a simple recommendation for rescuers managing a patient with an advanced airway in place, which was to provide 1 breath every 6 seconds when while continuous chest compressions were performed. So this was a rate that was easier to learn and execute than the previous guidelines that offered a range of different ranges of breaths per minute. And then here are the differences. So we can see that in 2015, there's now an upper limit. There's also an upper limit in the depths, right? But it's actually still the same compression ventilation ratio, except for the compression ventilation ratio with the advanced airway. Now, 2020. So the AHA's 2020 guidelines further refined CPR recommendations while introducing new elements, especially regarding post-resuscitation care and the chain of survival. One key update, especially regarding post-resuscitation, one key update, especially in the chain of survival, was the addition of recovery as a formal link in the chain of survival. This acknowledged the importance of post-resuscitation care, recommending different modes of rehabilitation for cardiac arrest survivors. So to address physical rehab, also neurological rehab, cardiopulmonary rehab, and cognitive impairments before discharge. And survivors, and not just survivors, but also their caregivers were advised to receive structured assessments for issues like anxiety, depression, post-traumatic stress, ensuring a comprehensive recovery support. By this time, that there was an emphasis on mental health also, aside from physical health. So in terms of CPR technique, there were no major changes to the 2015 cardiac arrest algorithms, but there were some significant updates that were introduced. So for example, for infants and children, the recommendation for BLS was to give one breath every 2 to 3 seconds. Previously, it was 3 to 5, right? Ensuring more frequent ventilation. And then epinephrine was also reaffirmed as a critical medication in CPR, particularly for non-shockable rhythms, with a recommendation to administer it as soon as possible, right? But if you remember, for ventricular fibrillation and pulseless ventricular tachycardia, the first dose of epinephrine should be given after initial defibrillation attempts have been given. Okay. New research also suggested that intravenous administration of medications was preferred over intraosseous cannulation, although IO could still be used if IV access was not possible. And another new element was the importance of, so we mentioned earlier that the mental health of survivors and their caregivers were emphasized. The update actually also included the debriefing and emotional support for rescuers, right? So whether the rescuer is a layperson, but including EMS providers or hospital staff after a cardiac arrest event, we all know how stressful it is to run a code or to even be part of the code. So this aimed to support the emotional and psychological well-being of all of those involved in such high stress situation. So here is a summary table of some of the differences in the updates of the CPR guidelines until 2020. So, as we've seen today, the evolution of CPR guidelines has been a journey of scientific discovery, technological innovation, and an unwavering commitment to saving lives. From the early days of chest compressions and mouth-to-mouth to modern high-quality CPR and the advent of AEDs for public use. Every update has been driven by one goal, and that is to give more people the chance to survive sudden cardiac arrest. We now know that the evolution of CPR is not just about what happens in the hospital. It's also about what happens before the patient ever reaches a healthcare facility. So whether you're a seasoned physician, nurse, or a newly licensed healthcare provider, each one of us plays a critical role in ensuring that this life-saving knowledge is applied where it matters most, in the moments when every second counts. So as I end my talk, let's remember that the science of resuscitation continues to evolve, and we are all part of that evolution. So let's continue to educate ourselves and others, apply these guidelines with confidence, and never estimate that we can save a life, one well-executed chest compression at a time, at 100 to 120 per minute, at 2 to 2.4 inches deep, allowing complete chest recoil, minimizing interruptions, and early defibrillation as needed. So thank you very much for your time and for your dedication to saving lives.
Thank you, Doc Roy, Dr. Allen Castre, for a very comprehensive and very interesting journey through the history of CPR, some of the early modalities that was used. That was amazing. Yeah, Doc, Are you available for some questions? We have a lot of questions coming through us from Facebook and YouTube. Are you still?
I'm not. Sige po, but I cannot see the ano, Doc. I cannot see the questions, but
Yeah,
yes, we'll try.
I'll just
Maybe you'll help me answer the
right.
questions.
Okay. All right. So Doc, we have some questions coming through in our Facebook live. So I'll just read it to you, no? So you won't be
Sige
able
po.
to see them in Zoom kasi, So I have a question here. In 1992, there was an inclusion for adults to call EMS first and
Yes.
then for children to do 1 minute of CPR first.
Mm.
What is the reason for this?
Right. Thank you, Doc. So then they realized that this actually has to do with the most common cause of cardiac arrest, right? So in adults, well, they figured that the most common cause of cardiac arrest in adults was because of a heart problem. So because the heart stopped, then the focus was on restarting the heart or doing what the heart, resuming the what the heart should be doing. But in pediatric patients, it was different because the most common cause in children was usually secondary to a respiratory failure, right? So if we focused on restarting the heart in children, but we did not, we forgot or we did not take into consideration the cause, then the the child would still go back to cardiac arrest because the main cause was actually a respiratory failure. So that is why the AHA recommended that in children, because the most common cause is respiratory failure, then it was as important as the breaths were as important as chest compressions.
Okay, thank you, Doc. Thank you for that very enlightening answer. We have one more question here. Why 2.4, which is only point 4 more from
Right,
inches?
right.
What what
Um,
what is the reasoning for this?
Well, I'm not so sure. I'm not so sure what the scientific answer is, but maybe it has to do with they found that uh, um, deeper compressions that were deeper than 2.4 inches. Actually, the difference between inches is just zero point 0.4, but if you look at it in centimeters, you round it up to the whole numbers in centimeters. There's a difference of around 2 or 1 to 2 centimeters, right? So they probably saw that there were a higher amount of injuries if the chest compressions were too deep.
Yeah. So just to add, Doc, no,
Oh yes, Doc. Please add, Doc.
this if there is one proof that women are the stronger sex, no, the basis of this study where they saw more injuries. What is fascinating to note here is that most of the injuries were only seen in men.
Mhm.
The lacerations and the fractures were only seen
Oh,
in male in male patients. No? So if
right.
there's you need any proof that women are the stronger sex, this study highlights this. No?
Mm-mm.
Doc, I have a very interesting question here. No? Uh, I'm a retired physician and already in the academe. I still remember the stacked shocks, and now it's
Mhm.
just single shock. So what is why did this change?
Right. So the reason why stack shocks was replaced with shock and then resume compressions immediately was because the focus was really on providing high quality CPR, right? So with high quality CPR, we want to minimize the interruptions between minimize interruptions, no, in the with the chest compressions, so that there is continuous flow of blood to the heart. So the tendency is if we give the stacked shocks, there is a it's going to take, well, the recommendation was for us to minimize chest compressions to not more than 10 seconds, right? And I think it would be logically impossible to give 10, I mean, to give three stacked shocks in less than 10 seconds. So that way, if we just give one shock and then we immediately resume chest compressions, whether that shock was successful or not, we're sure that the patient is still receiving blood flow to the important parts of the body, particularly the brain and the heart, especially if the shock was not uh, successful, right?
Doc, last question from the same doctor, follow-up question. Why change ABC to CAB? I retired from practice ABC. It's easier to remember because I'm
Right.
technical. Why CAB?
Right, right. I understand. But they realized, right, so in 2008, they studies, more and more studies showed that especially for adults, no, especially in adults, the critical thing was chest compressions. The bite was in 2008 where they saw that uh, studies showed that uh, patients who were given um, hands-only CPR were as it was as effective or comparably effective also as to those who were given conventional CPR. So, because the goal of the AHA was to encourage the involvement of more and more persons or bystanders to do CPR, and they realized probably that one of the major reasons why someone would not want to do CPR in the first place, because he or she might feel obliged to give breaths, right? So that's why kung ganun, they'd rather not start. So that really took a toll, and more patients did not receive CPR anymore. So they realized that by removing the breaths component, uh, more people would be willing to do CPR. So that's why the emphasis on compressions. So if you look at it, actually, um, it actually just placed priority on compressions. And you could even forgo the A and B, especially, di ba? So it's only one letter to remember than the ABC.
Okay. Thank you so much, Doc Roy. Those are all the questions we have on Facebook Live. So
Oh,
if anyone wants to have a follow-up question or ask questions live, you can do so now. But if you don't have any more, I'd like to thank you again, Dr. Alin Castro, for a very, very well detailed and very comprehensive and very, very amusing and interesting journey through the history of CPR. It really lends to more understanding and appreciation into the CPR guidelines. You never know, no? 10 years from now, they might be laughing at the way we do CPR.
right. Right, right.
Yeah. So you never
Oh,
know where the direction of CPR science will go. No, and
yeah.
hopefully, we'll still be around that time, and you can give an update.
Right. So we and also it would be we would encourage our students to stick with us every time we have a renewal of our of our CPR licenses, right? So because we will try to give the latest, the current evidence-based updates at the Academy of Emergency Sciences.
Right. Okay, I think that's it. Doc Roy, thank you so much. It was indeed an eye-opener. No? It was a very productive and very fulfilling morning. No? Thank you again. Thank you to all our
My
students
pleasure, Doc.
for attending
Thank you.
this great talk. We'll see you next month for our next REM, which was also very interesting. This will be covered by Dr. Manyalak, and this will talk about STEMI mimics, no, in the emergency room. So that's also going to be a very interesting discussion. So we hope to see you for our next REM next month. Thank you, everyone, and happy morning.
Morning. Bye.